Good evening to everyone. On behalf of SCII, I would like to welcome everyone for this month's webinar. We thought of doing it like an interactive session, and we had invited all members to share any questions they had regarding lung cancer staging. And I have shared it to our faculty, Dr. Asha, who will address all these questions that people have already sent. Plus, she will give a background about the staging of lung cancer. It's my great pleasure to introduce Dr. Asha. Dr. Asha Kandathil is working in UT Southwestern Medical Center in Texas and is a member of its Cardiothoracic Imaging Division. Her clinical interests include lung cancer screening, diagnosis, post-treatment follow-up. Her research interests include lung cancer as well as identification of imaging biomarkers to predict post-anesthesia complications and obstacles faced by patients who have received TAVI placement. Her research has been published in multiple peer-reviewed publications in multiple scientific journals, as well as multiple book chapters. I had the pleasure to be a co-author with Dr. Asha in our IRIA textbook, where she has written chapters on airway and ILD. Dr. Asha is on several academic and hospital committees, including the Medical School Admission Committee, the Thoracic Tumor Board, the Pulmonary Nodule Task Force, and Lung Cancer Screening Task Force.
Yeah, good evening, and thank you for allowing me to spend some time with you all. So we'll go straight into the lecture. We'll talk about the 8th edition of lung cancer staging. So as we know, imaging has a role to play in diagnosis, staging, and treatment response assessment. And lung cancer, around 85% is non-small cell lung cancer, of which most of them are adenocarcinomas, and around 30% are squamous cell carcinomas. And the TNM stage has been in use since 2017 worldwide, and in the US since 2018. And it's based on the prognostic data that was collected from an international database of over 70,000 people with lung cancer that was collected between 1999 and 2010. It involves the T stage, which is the size and degree of locoregional invasion by the primary tumor, and that's well depicted with CT. The N stage is the extent of regional nodal involvement, and CT and PET-CT have a role. And metastatic disease can either be intrathoracic or distant mets, and PET is very good at picking up those, the extrathoracic metastases. The stage from stage 1 to stage 4 is determined by the combination of the T, N, and M descriptors. So the goal of TNM staging is to look at the anatomic extent of tumor, and it is the most important predictor of survival. And it also provides a framework for therapeutic decision-making and facilitates exchange between multiple centers. So the TNM staging can either be clinical or it can be pathological. Okay, so it's preferable to have the pathologic stage, but then of course people who don't have, get resection, etc., will only have a clinical stage. And that is done with either with CT and PET-CT. So here, for instance, if you look at this nodule on CT, you can see that there are some spicules going towards the visceral pleura. And, the visceral pleural involvement is kind of indeterminate here. But when they look at it on pathology, they can say for sure whether the pleura is involved or not. And that will change the stage. So pathologic staging versus clinical staging. Now, when you look at the TNM, there are certain descriptors of the primary tumor that will tell you what the T stage is. Then the level of nodal involvement will give you the N stage, and whether there is intrathoracic or extrathoracic metastases will determine the M stage. And then you combine the T, the N, and the M to come up with a stage. So for instance, any patient with metastatic disease will automatically be a stage 4 cancer. Okay, we'll have stage 4 cancer. And like we said, the treatment is also based on, loosely on the staging. So for instance, in stage 1 and 2 people, you can do curative resection or you can do curative radiotherapy. Okay, so radiotherapy with curative intent. And with stage 3A tumors, they will do a combination of surgery and chemoradiation. Whereas once it becomes stage 3, which is N3 disease, and we'll talk about that, that's very important to identify. Patients are no longer surgical candidates, and it's chemoradiation. And for people with metastatic disease, there are like a lot of drug therapies, which can either be the conventional chemotherapy, molecular targeted therapy, immunotherapy, etc. And we'll talk about that later. So before we go into it, it's very important to understand the spectrum of adenocarcinomas from the pre-invasive to the invasive and how they appear on CT. So if you look at this pictorial, it's really nice how it shows the alveolar walls. And the tumor, it tends to spread along these alveolar walls without actually invading into the stroma. So this is what is called the lipidic pattern of spread, which you'd have seen in many pathology reports. And then once it invades the stroma and forms a solid component, you call it invasive cancer. And this is seen on CT as a ground glass opacity, which is this, the lipidic spread. And then you have the central invasive component. So this is what the, how the tumor will grow. First is the pre-malignant condition, which is the atypical adenomatous hyperplasia, which usually presents as a ground glass nodule that's less than or equal to 5 millimeter. Then adenocarcinoma in situ is the pre-invasive, and they are also ground glass nodules, but they can be up to around 3 centimeters. So don't ignore all the ground glass nodules that you see, keep it on follow-up. And if they're persistent, you got to be very aware that this could form into an invasive cancer. And in minimally invasive cancers, the ground glass component will still be around 3 centimeters, and then a small solid component will start developing. Okay, when the solid component is less than or equal to 5 millimeter, you call it minimally invasive. Once it becomes more than 5 millimeter, it becomes an invasive adenocarcinoma. And of course, a solid nodule can either be adeno or squamous, large cell, small cell carcinoma, etc. So let's look at the T descriptors. So the carcinoma in situ is called TIS. Then the T1 are tumors that are less than or equal to 3 centimeter, and they do not involve the main bronchus. And based on the size, from 1 to 3 centimeter, you can divide it into T1A, B, or C. So basically, T1 tumors are solitary pulmonary nodules. All right. T2 is between 3 to 5 centimeter, and they'll involve the main bronchus with or without, post-obstructive pneumonitis, atelectasis. So if you see any of those, automatically the tumor becomes a T2, regardless of the size. Even if it's a 2 centimeter tumor sitting in the main bronchus and causing atelectasis, that becomes a T2 tumor. And then, of course, visceral pleural invasion. Then T3 is larger tumors between 5 to 7 centimeter, and they involve the chest wall, and they may or may not have satellite nodules in the same lobe. So T3 tumors are still resectable. Okay, the nodule is also in the same lobe. You can treat it with a lobectomy. Now, T4 tumors are more than 7 centimeters, and they usually invade the mediastinum or, those structures that cannot really be resected. And there's a separate tumor nodule in a different lobe in the same lung. So if you want to treat this tumor, with the same thing, then you have to do a pneumonectomy here. So that's the T staging. So let's look at some examples. So this is a T1S, a purely ground glass nodule. Then once, there is this small solid or the invasive component, it's a minimally invasive. So these are pathologic diagnoses. Okay, this was a minimally invasive adenocarcinoma where the solid component was less than 5 millimeter. And then, like I said, the solid nodules, again, based on the size, from 1 to 3 centimeters can be T1A, T1B, or T1C. So this is a 2.5 centimeter right upper lobe nodule, which is a T1C tumor. Then for subsolid nodules, the total size of the lesion should be, for a T1 stage, the total size is usually less than 3 centimeter. That is the ground glass plus the solid component. But the actual T stage is determined by the size of the solid component. So we said that in minimally invasive, the solid part will be less than 5 millimeter. If it is between 5 to 10 millimeters, then it becomes a T1A. So basically from T1A to T1C, the solid component will vary between 5 millimeter to 3 centimeter. Okay, going on to T2 descriptors. So again, T2 is 3 to 5. So the 3 centimeter to 4 centimeter are the T2A tumors, and T2B is 4 to 5 centimeter. And then if it involves the main bronchus and causes atelectasis or post-obstructive pneumonitis, it becomes a T2 tumor. And here you can see the, on CT, it's very difficult to distinguish the atelectasis from the tumor, but PET is good at distinguishing that. And we'll talk about visceral pleural invasion later. T3 tumors are between 5 and 7 centimeter, and this can be chest wall invasion or a separate nodule in the same lobe. So we'll talk about like these nodules that you see apart from the primary tumor. So if you see a nodule in the same lobe, it's T3. If it is on the same side, but in a different lobe, it is T4. And once it goes to the opposite lung, it becomes metastatic disease, okay? So M1A is intrathoracic metastases. And that is what you'll have to label that as. Now, when you're talking about chest wall invasion, the most definite specific sign is bone destruction. Or if you see like soft tissue on the other side of the ribs, etc., obvious invasion, then you can call it as chest wall invasion. Now, if it's just abutting, it's very difficult to really determine. They say like some of the things that can be helpful are like if there is more than 3 centimeter contact between the mass and the chest wall, etc. And then dynamic cine images with MR or CT can kind of show if the tumor moves between the chest wall, if there's differential movement between the tumor and the chest wall. But the most specific symptom is like chest wall pain. So if a patient has a peripheral tumor and they complain of chest wall pain, then it's very likely that there is chest wall invasion, at least microscopically. T4 tumors are more than 7 centimeters, or like we said, a separate nodule in an ipsilateral lobe, or invasion of trachea, mediastinum, heart, any of those structures that usually cannot be resected well. But nowadays, like the surgeons are very aggressive. They try to, like resect all these vertebral body lesions and reconstruct, etc. Now, one thing that you have to remember is involvement of the diaphragm is considered as T4, not as T3. It used to be considered as T3, but they found that if the diaphragm is involved, the prognosis is similar to invasion of all the other mediastinal structures. So there are some questions. So I'll let Dr. Aparna ask these.
Thank you, Dr. Asha. That was a really detailed description of the T staging. So we have collated the questions that people have previously asked about T staging. There is also a question on the chat box. Let me address that question first. So that question goes as, if there is a ground glass density lesion, which is more than 3 centimeters, but has no solid component, what should the T staging be?
So the T stage will still be based on, I think it will still be a T1 tumor. We'll talk about that as we come.
Okay.
Yeah.
One more question is, if cancer is extending to the region of lymph node, do we include the node within the lesion measurement and upgrade the T staging? Do also mention that, or should we mention that contiguous nodal extension into the end staging? I think I understand what is being asked. Like if there is like contiguous nodes, are we going to increase, like add the nodes? Basically, we are not able to differentiate differentiate between where the tumor ends and where the node starts. So how do we go about when this happens? Should we include the whole thing as one mass and increase the T staging? Or should we include like kind of guess where the node is and make it go into the end staging?
I usually, do it as the end stage. Very often the tumor, it's very difficult to separate the two. But then, especially if there is other mediastinal lymph nodes, then you kind of expect it to go through the hilum. And I call it as an end stage, T and N.
Yeah, I guess because it is contiguous anyway, it will be like N1 or N2 because it will be on the same side, and there will be other nodes obviously. But yeah, sometimes it's really difficult to say where exactly the tumor ends, so that actual measuring for T staging may be difficult, I guess.
Yeah, but then if it goes into the mediastinum, then
It's anyway T4, right?
right,
Yeah.
yeah.
So that way, anyway, it's T4. So maybe finally the actual measurement may be difficult, but you may be able to say it's T4 because it's infiltrating the mediastinum.
Yeah. And that's the other thing. Like, we usually just give all the descriptors that will help the surgeon decide whether they want to operate on this patient or not. And also for the oncologist to decide what the actual TNM stage is going to be. So
Okay. I
I
think
don't know.
practices may vary. Yeah,
Yeah.
we kind of give the TNM staging whenever possible. Most often we do give. And sometimes even when the biopsy is not there, when we're pretty sure, we kind of say presuming malignancy, the staging would be such and such. I guess it varies between institutes
Yes.
whether
So
you
here what
actually give the staging on your report or not, or whether it is kind of decided in the MDT after everyone discusses.
right. Yeah. For us, it's usually decided, by the oncologist or, after the multidisciplinary tumor board, because they look at all the information. That is the CT, the brain MRI, the PET imaging, everything. And they give a final stage, with all this information together.
Okay.
So we don't put separate staging for each imaging investigation.
Okay.
But we always give, like anything that can upgrade the stage or whatever,
Yeah.
So.
So we'll go through some of the questions that people have asked about how do we measure the primary in certain situations, whether we measure it in lung or mediastinal window, and how do we measure when there are multifocal lesions. And if the dimension is larger on coronal view, should we take the coronal measurement, or should we take the maximum axial dimension? How should we take the measurement for the T staging?
Yeah, so you should always take the measure on the image that shows the greatest dimension, whether it is the axial, the coronal or the sagittal. And so here this tumor is 3.1 centimeter on the axial, so it becomes a T2A. So whatever is the maximum dimension is what you should take. Now, measuring, if it is the pure lung lesion, then you want to use the lung windows to measure. But then if there is mediastinal or a chest wall invasion, it's usually better seen on the mediastinal window. So, use both windows and see where you can see the tumor the best. Then for multifocal tumors, if it is a pure solid tumor, then the largest dimension, that's the T descriptor, will tell you what the actual lesion size is. For part solid lesions, you take the size of the solid component alone, not the whole ground glass. Now for pure ground glass, you take the largest dimension. So especially for these, when they become more than 3 centimeters, they look like these mnemonic kind of pneumonia kind of things, right? So they're the largest dimension. So, if it is more than 3 centimeters, it does become a T2 tumor or T4 or whichever, depending on the size. But then usually we don't biopsy ground glass nodules, and I don't think, I mean, it depends on whether you've biopsied and proven it to be a tumor. So what happens when there are multiple tumors? So it depends on whether you think there are multiple primary tumors. if you think it is a metastatic nodule, or if it is just multiple adenocarcinomas with pure ground glass features, or this kind of a mnemonic type of adenocarcinoma. So we'll talk about how do you distinguish a metastatic from a primary tumor. So it'll depend on each of these. So let's go to some examples. So we said if it is a metastatic nodule, if you think that it is a metastatic nodule, then if depending on whether it's in the same lobe, different lobe, or the opposite lung, the T staging will change. Now, how do you say that you favor a metastatic lesion? It'll usually have a similar radiographic appearance and a similar growth rate if previous imaging is available. So the second nodule also started around the same time or like subsequent from the primary tumor. And also, like, there is significant other metastatic disease like nodal and systemic mets and all that, then more likely that this nodule is a metastatic nodule from this primary tumor. Now, how do you distinguish synchronous tumors? So they'll usually have a different radiographic appearance, like the shape and the density. And then on PET, they may have different metabolic activities, and the growth rate will be different if previous imaging is available. And usually there is absence of nodal or systemic metastases. So here are two separate primary tumors. So you can see that they've biopsied both lesions. One is an adenosquamous and the other is an adenocarcinoma. So each of them will get their own TNM staging. Okay, so you don't combine the two. Now, if you see multiple of these ground glass nodules, and there are many, many patients who will have multiple of these, and you've got to keep them on follow-up and then look for development of the solid nodule, etc. Then what you do is, it's like this. So here, this lesion, the largest lesion or the most aggressive lesion had a solid component that was less than 5 millimeters. So this whole thing is a T1 minimally invasive. And then you put in parentheses that it is multiple, that is M. Okay. Then you give the N and the M stage for the entire group of tumors altogether. So that is how you would do these multiple ground glass nodules. All right. Then this is what is called this mnemonic type, where there is, diffuse ground glass and consolidative opacities, in both lungs and all that. So if it is measurable, the T stage will determine the actual size of the tumor in that one lobe. Then if the tumor is not measurable, then it look to see how many lobes are involved. It's similar to that satellite nodule. If one lobe is involved, it becomes a T3 tumor. If it is two ipsilateral lobes, it's T4, and M1A if both lungs are, if it goes to the opposite side. So this one would be a M1A disease. And this was a well-differentiated mucinous adenocarcinoma. So to your question that, the ground glass nodule, if it is more than 3 millimeters, if you think it is a tumor, then the T stage will depend on the tumor, the lesion size.
So you meant that it will still be T2, right? Even if it's ground glass, but it's more than 3 centimeters, it becomes T2. If it is a tumor, if it's proven a tumor.
Right.
Okay.
And then if it is, again, if it is involving one lobe, two lobes, but then it really depends on whether you've biopsied that and, or proven that it's an adenocarcinoma.
Yes. Some more further questions on T staging. How do you differentiate on imaging invasion of mediastinal visceral pleura, invasion of pericardium, invasion of mediastinal fat? Basically, all these will determine the T staging, but how do we determine that on imaging is the question.
Okay, so for mediastinal involvement, if you really see this, infiltration into the mediastinal fat. So this is the same as that first question that was asked, right? So we were saying that, usually when the hilum is involved, it will be a T4. Now, are there lymph nodes along with this? I think I would just have to say that, yes, probably there is, but we cannot really distinguish the nodes from the primary tumor, neither on PET. Then if there is infiltration of any of these structures, the heart, esophagus, anything that's in the mediastinum, then of course you say there is mediastinal involvement. Now, when are you kind of, when you're not very certain, then you look for a length of more than 3 centimeter or an obtuse angle between the tumor and the mediastinum. These are indirect signs. But, we're always very careful when we talk about, when we don't really see the infiltration, especially mediastinum or vessels, because sometimes when the surgeons go to operate, they can just kind of, get this off the the vessels or the mediastinum. It just kind of peels off. And they really have to look at it under the microscope to see whether there's actual, pleural involvement and all that kind of stuff. So the pathologic staging is much better, but these are the things that we can kind of tell them. All right. Then visceral pleural involvement. They say like there's not really enough evidence to say that, anything with pleural tags and all that can be upstaged from a T1 to T2. So very often we see these pleural tags, and what they say is that they can, on histopathology, it can be thickened interlobular septae from localized edema, tumor extension within or outside lymphatic vessels, or inflammatory cells or fibrosis. Okay, so any of these can cause these pleural tags. So none of this is really specific, but these are all things that you want to really mention in your report. So if a surgeon wants to operate, they can be aware that there may be pleural involvement, and they'll be more careful in their dissection. Then pericardial involvement. I took this, usually we look for it more with thymomas. What we really look for is this, loss of the fat plane along with thickening of the pericardium. And like I mentioned earlier, very often these tumors just kind of peel off from the pericardium, except, if there is like pericardial thickening, etc. So this one, if there's thickening, then you can be more definite that it is pericardial involvement. Okay, any questions on that?
So the next questions asked were, how do you stage superior sulcus tumor? Is MRI mandatory for this, or can we stage it on CT itself?
So most often you can stage it just on CT. Okay, MR is indicated only for if you want to look for preoperative involvement of the brachial plexus, and of course, like for spinal cord involvement, right? If the cord is being compressed, then you would do an MR. So superior sulcus tumors are at least T3 tumors because of chest wall invasion. Now the T4 are the ones with brachial plexus involvement above T4, involvement of the vertebral body, spinal canal, subclavian vein, etc. And all this you can really see very clearly on the CT. Now, if the surgeon wants to operate, then, if they want to know very definite features like, is there brachial plexus involvement above T1 level, etc., then you may need to do an MR, not otherwise. And so here's one case where you can see that there is this large mass, and on the CT, it's very obvious there's bone destruction and involvement of the chest wall. And I just want to show you this. This is the FDG PET CT, but see how like the FDG extends beyond the actual level of the tumor, right? So that is a blooming artifact. So if you want to say there's a tumor that was abutting the chest wall, this kind of blooming will happen on this side also, right? So PET can overestimate chest wall involvement. And so it's not the best modality. CT or MR are much better than PET to look for chest wall invasion, etc. Now, this is the MR for the same patient. And there is thickening and enhancement of the, the brachial plexus. And so MR is important or helpful to evaluate this, or the extent of the chest wall involvement.
Next question was, what is the role of PET-CT in T staging? Can PET negative nodules be ignored? So often we see this, like there may be a tumor on one side and there may be some tiny nodules in the other lung, and they'll be PET negative. What do we do? Like, should we label them as M1A, or should we ignore them because they are PET negative? Or that is the question.
Right.
Is
okay. So the radio tracer that's used for oncology PET is F18-FDG. So FDG is fluorodeoxyglucose. So it's a glucose analog. So that's in anything that has increased glucose metabolism will light up on these FDG PET CTs. So that includes tumors, inflammatory cells, and there are a lot of normal variants. Like say a person talks or the muscle gets activated for some reason, then, there'll be a lot of uptake into that. And then there is something else called brown fat, people who have these metabolically active fat, very often you see it in the paraspinal regions, etc. So there are a lot of normal variants, pitfalls, and all that when you're looking at a PET CT. Now, the importance of PET and T staging is basically, first one is, of course, to differentiate the tumor from the post-obstructive atelectasis, and this will help in radiotherapy planning and targeting. Like I said, you have to be aware of all the false positive and false negative things that you can see with PET. So you can have false positive uptake in infections, inflammations, in benign tumors, etc. So this is an example of a nodule in the left lung, and biopsy of this revealed pneumonia. Okay, so you have to be aware of infections. And so, according to NCC guidelines and every other guideline, due to the false positive results in infections and inflammatory lesions, FDG PET does not replace biopsy, but guides tissue sampling. Okay, so you can just kind of say that, okay, this thing might be a tumor, but you should never forget that infections can be PET, FDG avid. And of course, there are a lot of false negative lesions. So anything that with low cellularity or something that's very small, anything that is less than 8 millimeters, I would say, or micrometastases will not be FDG avid. So here's a mucinous tumor, and you can see it's not FDG avid. Similarly, this ground glass nodule that is in the upper lobe, because of this low cellularity, it is not FDG avid. So how do you approach a PET negative solitary pulmonary nodule? So this is not for the metastatic nodules, but if you think that somebody has a very low pretest probability of malignancy and the lesion is negative, then you can just put them on serial CT follow-up. But if the patient has a high probability of having malignancy, say it's a smoker and a family history of cancer, etc., then you have to be a little more aggressive about obtaining a tissue sample or resection. Okay, so you should never go by the FDG uptake alone. You should always look at the morphology of the tumor as well as the growth pattern. I've seen like multiple cases where it's a like ugly looking spiculated tumor that just has been sitting around for some time, and it is PET negative, but you still say that, okay, the morphology is very suspicious for a tumor and the patient needs a biopsy. And sometimes the biopsy is also negative, if they go and biopsy the periphery where there's more inflammatory cells, etc., they may not get a proper tissue sample. And then we ask them to repeat the biopsy because the morphology is really very important. Okay, so you have to go by the radiologic features and the FDG ability. So you can see this lesion from 2015, it's been gradually growing and it's becoming more solid. So this is like very, very, very suspicious for a tumor, right? And it is not FDG avid. But, you still say that this is very suspicious, and biopsy turned out to be an invasive adenocarcinoma. Now, this is just to show you that same example I showed you earlier. See how the PET is, see the FDG uptake is only in this solid component of this tumor. All these ground glass areas don't really show any uptake. Similarly, there's so much more tumor here, and there's just a small portion of it that is FDG avid. And this one is just not even FDG avid. So just don't go by the FDG uptake alone. Look at the morphology of the tumor as well. Okay. Shall we go to the cases? Aparna, any other questions?
No more questions in the chat box. We can go through the cases.
Yeah. All right. So these were some very interesting, nice cases that were sent. So here's one, right upper lobe adenocarcinoma with acinar pattern, no mutations of the EGFR gene analyzed, etc. How do you stage these tumors? So I'll just go through a couple. So the second one again, right lung mass biopsy, invasive mucinous adenocarcinoma with predominantly lipidic pattern. So these two tumors, so what do we see here? We see a more consolidative tumor here in the right upper lobe. Here also, again, it's more like diffuse ground glass, consolidative opacities. And then, I think this is an emphysematous space that's in the middle here. And then there are these multiple nodules and ground glass opacities on the opposite side in this patient here. And here again, there are these multiple nodules. Some of them have this ground glass kind of, a tree and bud appearance. Some of them are looking a little cavitary, etc. So how do we approach these cases? Now, the solid part of it, for instance, if it is like, you go with that mnemonic type of tumor, right? If it is measurable, then the T stage is by this. But here you can see that there is like in both lungs, right? So it's automatically M1A stage here. Then here's another case where CT-guided lung biopsy from the lingular nodule showed adenocarcinoma with a predominant acinar pattern. And then there are all these multiple nodules bilaterally. So how do you approach adenocarcinoma with multiple pulmonary nodules? So adenocarcinomas can spread either the lipidic spread, like I showed you, along those alveolar walls. You can have airway metastases, you can have lymphatic metastases, and hematogenous spread of tumor. So in intrapulmonary aerogenous mets, you'll have these bronchocentric or centrilobular nodules. Okay. Then the lymphatic metastases will be like this lymphangitic carcinomatosis, where there is the perilymphatic nodules with interlobular septal thickening, etc. And then if it is a hematogenous mets, then you have randomly distributed nodules. So if you look at these nodules here, some of them we said had this kind of a train bud appearance, right? So some of this I think is aerogenous mets from the primary adenocarcinoma. And then some of these here, like they touch the periphery of the lung, near the pleura. So that is probably like some degree of hematogenous metastases as well. So all these nodules look like metastatic lesions. Now, there is a sign called the Cheerios sign, where, if you see these one or two nodules of variable size with this hypodense center, it's supposed to be due to the proliferation of malignant or non-malignant cells around an airway. And your differential diagnosis. So this was another example of an invasive adenocarcinoma with this Cheerios sign. So the differential is adenocarcinoma, metastatic adenocarcinoma, and then of course other metastatic tumors. But some inflammatory conditions like vasculitis and LCH can also cause this sign. Okay, so here overall in this one, you see these kind of train bud nodules, you see the Cheerios sign, you see some random nodules. So overall, I think that all these are metastatic lesions. And since it's involving both lungs, this is going to be M1A for both these, all these three cases. Now there's another, okay, so this is the next case. And here, this was a part solid nodule. Okay, so again, how do you stage part solid nodules? And like, as we mentioned, you have to go by the size of the solid component. Okay, but you have to include the total dimension of the tumor in your report as well. Here was another case, case 5. There's a large primary tumor, and there are these opacities in the right upper lobe as well as in the opposite lung. Now, this lesion itself, I think, is probably more than 7 centimeters. Say it's a T4 tumor. Now, these lesions, to me, they look like train bud with bronchial wall thickening. They don't look like those strain buds without the bronchial wall thickening that we saw in the other case, right? And even these kind of look like train bud. Only if we have like the rest of the images, I can actually say what they look like. But I would think that this is more of an airway process, like an aspiration or an infection. And I would go down that differential and ask them to treat and to follow up and see if they resolve. So between these two cases, if you look at these train bud opacities, there's no bronchial wall thickening or anything. So I think this is like more like a metastatic lesion, whereas this one, to me, it looks like there's bronchial wall thickening and then the train bud things, which I think is similar on the left side as well. And I would think that this is more like infection or aspiration. Any questions on this or any comments?
I don't see anything on the chat box. I request anyone who has any comments or questions to please put it on the chat box. I think we can move ahead. If anything comes up, we'll address it.
Sure. So let's go on to end descriptors. So on CT, mediastinal nodes more than 10 millimeter, but supraclavicular more than 5 millimeters are considered to be pathologic. Okay. So if there is a tumor on one side, if there's hilar node involvement, ipsilateral hilar node involvement, that is an N1 disease. Then N2 is ipsilateral mediastinal or subcarinal. And once it goes to the supraclavicular or to the contralateral mediastinal lymph nodes, it becomes N3 disease. Okay. Now this is the IASLC lymph node map. And, you know, our CT staging is based on that. So here's a PET image showing you a primary tumor in the right upper lobe. And then there is hilar lymph nodes. So that would be, if it was just the hilar node, it would be N1. Then there is involvement of the subcarinal as well. So subcarinal involvement is N2 disease, but the patient has a supraclavicular node. So this becomes an N3 disease. And that upstages it to a 3C stage. Okay. Now it's very important to distinguish like the nodes that will separate N2 from N3 and N1 from N2. So N3 we said were supraclavicular, but N2 were paratracheal. So at the thoracic inlet, what you have to do is look at the where the first rib is. Anything that is anterior or superior to that are considered to be in the supraclavicular region, and they become N3 disease. Whereas anything that's inferior or posterior will be N2 disease. Okay. Similarly, very important to distinguish hilar from the lower paratracheal nodes. And this is one of some of the common pitfalls. The lower margin of the azygous vein distinguishes the hilar from the ipsilateral mediastinal, N2 from N1, okay? And on the other side, it's the upper border of the pulmonary artery, so anything that's above that is a paratracheal, anything below that is a hilar node. Then another thing to remember is that the left lateral wall of the trachea is considered as the, it is used to divide the right from the left. It's not the midline trachea. Okay, remember that. Okay, this is also important to distinguish a station 5 from a paratracheal lymph node. Okay, left lower paratracheal lymph node. So here, what you look for is this, the ductus arteriosum. You may see this calcification. Anything that's lateral to that is a station 5. Anything medial to that is a paratracheal node. Now, this is very important because most often the biopsy, the sampling is done through the endobronchial ultrasound guidance, right? So you can only get a station 4L node, the paratracheal node, through that. It's not possible to sample a station 5. This will need a mediastinoscopy, right? And then, of course, the inferior margin of the aortic arch and the superior margin of the left pulmonary artery. This is the region where the station 5 nodes dwell. Now, this article is really, really very good for identifying nodal stations on CT. It's from 2014 radiographics. Okay, so we have a few questions on end staging.
So how do you stage when there are abdominal nodes or retrocrural or diaphragmatic nodes?
So there are like studies have shown that lung cancers have certain fixed patterns of spread. Like for instance, the right upper lobe tumors will go mostly to the paratracheal and to the hilar regions. The left upper lobe will go to the hilum, and a lot of them will go to the station 5 nodes. Similarly, the right lower lobe will go to the subcarinal, the hilum, or to the paraesophageal and the station 9. So that's the reason why this IASLC, they have this nodal map. This is the common sites of nodal metastases from bronchogenic carcinoma. Now, to find mets to internal mammary, axillary, diaphragmatic, etc., is very, very uncommon with lung cancers. So that's why, like anything outside of this staging map, you call them as metastatic disease. Okay. So cervical, axillary, retrocrural, diaphragmatic, etc., abdominal, they're all called as metastatic disease. So, so here, for instance, there's this large tumor, and you can see these non-enlarged lymph nodes in the neck, but they're very avid on PET. And biopsy showed that these were metastatic nodes from adenocarcinoma. So this is another big advantage of PET. It will show you unsuspected sites of metastases. But like we already mentioned, this has to be sampled and proven to be mets and not an inflammatory lesion. All right. So next question.
Can we label PET positive but subcentimetric nodes as positive?
Okay. So like we said earlier, PET will have a lot of false positive and false negative results, right? So it's better not to call it as, definitely positive. You can just say that there is this small node which was positive on PET. But then again, they have to sample that to say whether it is actually malignant or benign. So CT, you use a criteria of more than 1 centimeter, and that has a sensitivity of around 61% and specificity of 79%. PET has a higher sensitivity and specificity, but again, remember the false positive. So according to the NCCN guidelines and all that, even if PET is positive, you have to do a pathologic confirmation. Now, how do you sample? It's usually with endobronchial ultrasound. So say the endobronchial ultrasound guided biopsy is negative, but PET and CT are positive. There's nodes that are more than 1 centimeter, etc. Then they have to do a repeat stenoscopy and biopsy if they're considering surgical resection. Okay. But what if the nodes are negative? Then what they do is, like, if it is a central tumor, they would still sample it. But if it is a solid tumor that's less than 1 centimeter or a pure ground glass that's less than 3 centimeters, then they will not do a repeat sampling. Okay, there's 1 or 2 cases. So again, this was that same one where we thought, there was this tumor and metastatic disease, and then there are these 2 nodes. So now it should be pretty clear, right? So if you look at the ligamentum arteriosum, you can see that there is 1 node lateral to it and 1 node medial to it. So this would be a station 5, and this would be a 4L lymph node. Then the diaphragmatic nodes, and then the paratracheal lymph nodes. So like we said, based on the pattern of spread, this one would be a 4R. This one, depending on the size, like, whether if you think it's involved, then it becomes a metastatic disease. All right. Shall we move on to M descriptors?
Yes.
Yeah. All right. So M1A is intrathoracic mets. So separate tumor nodules in the contralateral lung, malignant pleural or pericardial effusions. M1B is a solitary extrathoracic mets in a single organ. So if there is, like there is only T tumor, like the main tumor, and then you look at the nodes, and then you see a single met in a brain met, or a single adrenal met. Okay, you cannot have multiple brain mets. It has to be a single met. Or say there is a single periportal lymph node or something. Then you call it M1B. Now it's important to distinguish the M1B from M1C, because in M1B, the patient may still be a candidate for primary resection of the lung cancer, etc. And also they can do definitive treatment for that solitary met. They can do, either a definitive radiotherapy, or they can resect that solitary met. Now, M1C is multiple mets in a single organ, or multiple mets in multiple organs. And now again, see, this is another advantage of PET. PET is very good at looking for extrathoracic metastases. So there's a lung cancer, and you can see like multiple soft tissue metastases. Then M1A is separate tumor nodule, like we said, in the contralateral lung, or malignant pleural or pericardial effusions or nodules. So usually, if you have these enhancing nodules, definitely, we know that they are going to be pleural metastases. And most pleural and pericardial effusions with lung cancer are malignant. But we'll talk about that a little later. And then here's an example of an M1B lesion, where there is a T3 tumor, and then a solitary met in the left adrenal gland. So this one, both can be resected. Then M1B, of course, is multiple extrathoracic metastases. And PET is very, very important in this, because if they're trying to do any curative therapy, PET can identify these unsuspected mets and reduce the frequency of futile thoracotomies. Okay, we have some questions.
So how can we stage small effusions, which we cannot tap, or if there are small effusions and we tap and it's just an inconclusive result?
Yeah, so these are the NCCN guidelines for pleural effusions. So what they say is most pleural and pericardial effusions with lung cancer are a result of the tumor. But in some patients, despite like multiple microscopic examinations, if the fluid is negative, it is non-bloody, not an exudate, and then based on clinical judgment, then they can say that it is not related to the tumor. Okay. All right, another question.
So if CT of the chest and abdomen, if just CT does not show metastasis, should we say M0 or should we say MX? I think what they mean is, is PET and MRI brain mandatory, or is chest, CT and abdomen enough to give the M staging? And if PET CT is not available or not affordable, like in India, I think many of the smaller towns, the PET is not available because of the non-availability of the FDG. How will it affect the management? Basically, it's coming to the same question: is PET mandatory for staging, or and if it is not there, how do we stage it?
Yeah. So I would, request all of you to read this wonderful article by Dr. Aparna and colleagues. So these are the imaging recommendations for diagnosis, staging, and management of lung cancer. And it's published in the Indian Journal of Medical Pediatric Oncology, okay, earlier this year. So this gives a very comprehensive look at how to approach, all imaging related questions for lung cancer, post-treatment assessment and everything, okay? And according to them, from this, they said that Indian Radiologic and Imaging Association guidelines, okay, they say that FDG PET is the most accurate investigation method for staging. But if PET is not available, then you do a contrast enhanced CT of the thorax, abdomen, and pelvis, and a whole body bone scan. So that's how you do the complete staging. Now, according to the NCCN guidelines, PET CT is recommended for stage 1 to 4 non-small cell lung cancer. Okay. And like we said, because of the high incidence of false positive, you can biopsy the lesion that will confer the highest stage. So say the patient has a lung cancer and there are some mediastinal nodes, but then you think there is a bone lesion that looks like it's going to be metastatic, then you have to biopsy the bone lesion to confer the highest stage. Yeah. And next question.
Sorry, is MRI brain mandatory for all CA lung patients, or only if they are symptomatic, or only if there's any suspicion on PET-CT? I think
PET,
somebody's audio is on. May I request the ones who are not talking to please switch off their audio?
okay, so basically the brain, uses up a lot of glucose. So in all PET CTs, the brain will take up a lot of FDG, okay, and that can obscure any metastatic lesions. So because of the high incidence of brain metastases, brain MRI should be performed in all patients with non-small cell and small cell lung cancer. Okay, PET is not used to look for brain metastases. And you can see the NCCN guidelines for both non-small cell and small cell lung cancer. They advocate brain MRI for all these patients. Now, for non-small cell lung cancer, they say like from stage 2 on, it is mandatory. But stage 1B, it is optional. All right.
Is there any difference in staging based on the histological subtype or molecular markers?
All right. So we saw this nice example case that was sent by one of our colleagues. This was an adenocarcinoma, and you can see like the pathologist has given all these different things, right? No mutations in the EGFR, etc. things. So that is the molecular profile of that tumor. So in the 8th edition, the classification is based just on how much the tumor has spread. It's just based on the anatomic extent. The molecular tumor profile is not part of the TNM staging. And we don't know what they're going to do in the 9th edition, but I think it's still just going to be the anatomic extent. All right. Now, the extent of tumor, that is the TNM staging, is the most important determinant of prognosis. But then once the tumor is disseminated, then like all this molecular profiling and all that becomes much more relevant. Okay. So right now, TNM does not include the molecular profile. So let's just look at the pathology. I think like some people have covered this before, but we'll just quickly see how lung cancer is diagnosed. So first, when they get the sample, biopsy sample, first they look for the morphology, the histologic examination, and try to see whether it is a small cell, non-small cell, and then subtype it, okay? Now, sometimes it's very difficult to determine whether this is a squamous cell carcinoma, an adenocarcinoma. Sometimes it's very difficult to say whether this is a primary squamous cell from the lung, or is it a metastatic squamous cell from a head and neck, etc. So there, they would use immunohistochemistry to try to distinguish adeno from squamous, etc. Okay, that is one. Now, after that, after the diagnosis, then they look for some molecular characteristics of the tumor that will be very helpful for treatment. So if you look at this one here, like we said, looking at the cell type, they first try to see whether it's a non-small cell, small cell, etc. And then they do some of these stains. Okay? So for instance, in an adenocarcinoma, it will be TTF1 or napsin positive. And whereas a squamous cell carcinoma will be P40 positive. Okay, so you'll see all these different stains. So this is an example of 3 different patients, like 3 different squamous cell carcinomas. And then this is a P40 stain. So this much is diagnosis. The next thing they do is to look for molecular targets, which can be used for treatment. So these are some of the molecular targets that they're looking for, like EGFR mutation, ALK rearrangement, etc. Or they may look for what is called PD-L1 expression. So this is to see the amount of whether they can give immunotherapy. Okay, so very briefly, I'll talk about these molecular targets and therapy. So cancer cells form because of the DNA mutations that cause these normal cells to grow uncontrollably. So some of the key molecular aberrations that have been found in lung cancer are, what is called the like mutations in this EGFR protein. So this is actually it's on the cell surface. So if there is an activating mutation, it's called. So what happens there is it functions like too much, So say this EGFR, it's supposed to kind of do signal these proteins downstream, and that is what controls the proliferation of the cells. Now, if this is overactive, it's going to kind of continue to proliferate too much, and the cancer cells form. So if you find an activating mutation in the EGFR by those molecular profiling, then you can give drugs to block it. And those are these erlotinib, etc. Okay, so that is the basis of molecular targeted therapies. You find aberrations in the cancer cells, in the genetic mutations, and you give drugs to target those. That is molecular targeted therapy. Now, immunotherapy is a little different. So here what happens is immune checkpoints are naturally occurring inhibitory signals that occur in our bodies. And that is what prevents autoimmunity, okay? And some of these things like the CTLA4 and the PD-L1, these are all proteins that are found in normal cells. And that will, the T cells will see these cells and say, oh, okay, they're part of our body and we should not be attacking them. And some of these cancer cells, they'll use these checkpoints and they also pretend to be part of the body. And so the immune system does not attack these cancer cells, all right? So the immunotherapy is where you give these checkpoint inhibitors. And these are these drugs called this pembrolizumab and nivolumab, etc. What they'll do is they are antibodies that they'll go and block this PD-1 and the CTLA4, all those antigens. And then the T cells start recognizing these tumor cells as foreign to the body, and they'll start attacking them and cause death, okay? So that's the difference between targeted therapy and molecular targeted therapy and immunotherapy. So the treatment approach prognosis is dependent on the TNM stage. So the molecular profiling is not a part of the TNM stage, but all these genomic characteristics, the histology, the amount of FDG avidity, etc., they're all very important in determining the prognosis and also in determining the treatment for the patient. All right. We have a few other questions.
So incidentally detected tiny nodules in lungs in upper lobe, say 6 millimeters in a case of head and neck malignancy. What should we do? Should we follow up, or should we use Fleischner Society guidelines, or should we use British guidelines? What should we do in incident?
Yeah, so here we use this one, there was like a paper from the Mass General group of management of incidental pulmonary nodules. Now, in patients who have known malignancy or who have who are immunocompromised, say somebody who's had a bone marrow transplant or something, you should not treat those nodules the same as you would with an incidentally detected nodule. So the Fleischner Society guidelines and all are for incidentally detected nodules, right? Now, in someone with a known malignancy, your suspicion for metastatic disease is much higher. Similarly, for somebody who's immunocompromised, you're thinking of fungal infections, etc. So you should not be following them up at such large intervals, right? So in patients who you think have in patients who have a history of malignancy within the last 5 years, you ask for follow-up in 3, 6, 12, or 24 months, okay? Now, sometimes these people are on like some clinical protocol. So in our report, we always say, do a follow-up CT in 3 months or according to the oncology protocol. So, so the clinician can decide how they want to do it. Now, if the nodules continue to grow, then you're more suspicious for metastatic disease, and then you ask for biopsy, etc. Now, for patients who are immunocompromised or you think might have an infection, then you should not even be waiting till 3 months. It should be like within 4 to 6 weeks. You want to follow up these nodules to see if they resolve or they are like some other kind of infectious disease. Now, Fleischner Society guidelines, those are used for, say you find these incidental nodules when you're doing a CT pulmonary angiogram, then you go by the size and you do the follow-up CT. And then if you do, of course, when you're doing the lung cancer screening, that's a different set of recommendations. That is the lung RADS, because there you expect the patient to come back every year for the screening, right? So there you may wait for the annual screening can be done, for even a little larger nodules as well, because the patient is going to come back, right? So that's how you approach nodules depending on the clinical situation.
Okay, so I'll just summarize again what you said. So if it is totally incidentally detected, then we can go by the Fleischner Society. Whereas if they are on screening, it is the lung RADS. And if it is a known malignancy and we are finding tiny nodules, then we'll have to follow up more quickly than the Fleischner Society. So next question is, which risk calculator do you suggest for solitary pulmonary nodule, Brock or Mayo Clinic calculator?
So, the lung RADS, the ACR, the American College of Radiology, they, have encouraged radiologists to use the McWilliams. Okay. So that is the one which is the Brock calculator. So I think that was it. So we'll just summarize. So TNM stage is basically the size of the tumor, the extent of nodal involvement, and metastatic disease. And you use CT, PET CT, and then you always have to do a brain MRI to look for brain metastases. And then the T stage is a combination of the T, N, and M descriptors. So this was a nice template from this article where they say, like, what are the kinds of information that you want to give, especially if the surgeon is going to think about resection. Then you want to say where it is, and then the number of lobes that are involved, the size. Then very important to say whether it's crossing the fissure, because, here you cannot, the surgeon cannot just do a lobectomy. They may have to do a lobectomy plus a wedge of the lower lobe, right? Then you want to say how, whether it's close to the pleura, then, whether there is mediastinal invasion, is there main bronchial involvement, because that becomes a T2 tumor, and then chest wall invasion. You want to say whether it's adherent to the pleura or, opposed to the pleura, and then all those nodes, and then look for metastatic disease. All right. Thank you. That is it. Any questions?
Thank you so much, Dr. Asha, for a very nice comprehensive review. A lot of our doubts have got cleared. I'm very thankful to you. I'm just seeing if anyone has any other questions or comments, request you to please put it on the chat box. I don't see any other questions as of now. So thank you once again, Dr. Asha, and thank you for all the audience who has been sitting here on the Saturday afternoon and listening to this very interesting lecture. Yeah, there are some comments coming saying thank you so much for the wonderful talk. Thank you once again, Dr. Asha.